We are continuing our antepartum lecture with diagnostic tests. So there is a list here for you. We can do a vaginal ultrasound as early as 5 weeks, and this vaginal ultrasound is done to confirm pregnancy and gestational age. Another diagnostic test that could be done, remember we talked about the maternal serum AFP, and if those markers are low, then it could say maybe 1 in 50, and it can mean that the baby is might have some challenges, Down syndrome, maybe neurotube defect. They're just you have markers 1 to 50. So there are things that the patient, mom, or pregnant patient can do to get more specific diagnostic testing to find out about chromosomes. So another test that she can get done is a CVS. Normally not routinely covered by insurance. It's about a couple $100. Not routinely done. And how it's done is through a small specimen tissue from the fetal portion of the placenta. Okay, it is for genetics or chromosomal abnormalities, or maybe a patient that is over the age of 35. Okay, CVS sampling does determine fetal karyotyping, sickle cell anemia, PKU, Down syndrome, and Duchenne's muscular dystrophy. So it does say a lot about this fetus, and it calms mom a bit because it could be very anxious. Okay, there could be lots of anxiety with mom if she finds out that, for example, she has an AFP and the markers are 1 in 50. That's really low numbers, that something could be wrong with her baby. So there are diagnostic tests that she could do. Now going back to our list here. So this is CVS. The results are ready in about a week. And usually, of course, CVS is probably not the first one that the patients will go to because it's the one that's not covered by the insurance, unless it's a well worth spent couple $100 if the patient is able to pay for it. Again, let me give you a page number in your Pilotary book, page 164. Then we're going to talk about amniocentesis. We have a picture, the amniocentesis. It is also done, and we have to have an ultrasound, and then of course you have the needle to take some amniotic fluid. And amniocentesis, the results, this is covered by insurance, and the results is about 10 days to 2 weeks. Also in Pilotary, you can find information where it talks about amniocentesis on page 194. It is done between 15 and 18 weeks, and it's to determine genetic disorder. Also done more than 30 weeks gestation to assess the Ellis ratio. Ellis ratio determines fetal lung maturity. So it's usually a 2-to-1, and it determines fetal lung maturity. LS, just like it says, L is lecithin, and I'll spell it out for you, lecithin over sphygmomyelin. That's the S. sphygmomyelin. Okay, to assess the Ellis ratio, lecithin over sphygmomyelin, that determines fetal lung maturity. So an amniocentesis could be done for genetic disorder, and it could be done if patient is more than 30 weeks pregnant, 30 weeks gestation pregnant, to assess the Ellis ratio. And going back to our list, we've got, again, maternal serum alpha-fetoprotein. that could be done between 15 and 20 weeks. And that is where it determines for neurotube defects. A little bit on the alpha-fetoprotein. You're going to hear this a lot, maternal serum. That's where the MS comes from, alpha-fetoprotein. This is a blood test that checks the levels of AFP in a pregnant woman's blood. Now, AFP, alpha-fetoprotein, is a substance made in the liver of the unborn baby. Okay, now the level of AFP in the blood is used as a maternal triple serum, okay, or quadruple screening test. Usually it's a triple test, and sometimes instead of calling it maternal serum AFP, it's called the triple test. Okay, that's usually done in the second trimester, and it's an AFP. They do levels. They do the AFP. They also do the HCG, and they also do estrogen levels. Okay, so the triple screen, as we call it, the triple screen checks AFP, ACG, HCG, and a type of estrogen. Okay, the levels of these substances, along with the woman's age and other factors, help the healthcare provider determine or estimate the chance that this baby might have certain problems or birth defects. Okay, something else that is also done, okay, another screen that's also done, if these markers come low, another screen that's used to see if your baby has certain birth defects. If the screening is positive, okay, something else we could do is also an ultrasound. Okay, it's checking for nuchal translucency. And nuchal translucency, it's the thickness of the skin and back of the fetus neck. So that is looked at in ultrasound as well. So the AFP comes back, the markers are low. They can do, and sometimes the AFP is done with this triple screen, okay, of the AFP, and they look at all these levels together, and they're going to determine, that this baby is more, is more likely to have birth defect. You might want to have some diagnostics to make sure, and then of course followed with the AFP come, as we said before, the amniocentesis, because it's going to look at the chromosomes. Then we're going to do CVS sampling. That also could get done, and it's going to look more into chromosomes as well. Okay. In some cases, there's a combination of screening test that's done in the first trimester to look also for Down syndrome. Okay, and that is the ultrasound for nuchal translucency. And then also they can even go even further. Just want to let you know that there are diagnostic tests that could be done. So with prenatal care, with doing your labs, with getting the lab work back, there are screening tests that could be done. Something else that can be done also, combined screening test. They are more accurate, okay, as the second trimester, the screening exams that are done, okay, like that triple screen as well. The other ones that are done are, they could do a beta HCG, and I want to let you know, because if you hear these terms, I want to let you know what they are. Okay, so more testing done. Okay, so in some cases, there's a combination of screening tests that are done in the first trimester to look for Down syndrome. This is where I told you they have the ultrasound measurement of the thickness of the skin at the back of the fetus neck. Plus, they can also do a blood test of the levels of the pregnancy hormone HCG. And also they can get done a protein that's called, actually you'll hear the PAPA, okay? And it's pregnancy associated plasma protein, okay, A. Okay, so next one that could get done, we can also do a beta HCG levels and also the PAPA, which is a pregnancy-associated plasma protein A. Okay, and these combined screenings are about as accurate as also that second trimester maternal serum. Okay, so this can be done in the first trimester when they do the ultrasound, and we can do the beta HCG and the PAPA, and then in the second trimester, that's when you're going to have your maternal serum AFP. Okay, and usually it's going to be that triple screen with AFP, HCG, and estrogen. Okay, so just a little bit on what that maternal serum alpha fetoprotein is, and again, the alpha fetoprotein, that maternal serum test can help find an omphalocele, okay, which is the congenital problem which some of the babies' intestines stick out through the belly wall, through the abdomen, okay, and also the chromosomal problems, Down syndrome. We also have trisomy 21, trisomy 18, so very specific to chromosomes. Okay, but then again, we talked about if those levels are off, then we talked about doing an amniocentesis for chromosomes, and we talked about doing a CVS for chromosomes as well. Then you can also do further testing, and that's your percutaneous umbilical blood sampling. That is done, and some pictures there. Okay, again, this one's not routinely done, but if you get those markers like that, the anxiety level of the parents, of the mom is very high. So you can, be more specific. This one's also not routinely done, but it allows for more rapid karyotyping, and you can see the karyotyping. You can see right here with the chromosomes. Okay, so you specifically, you're just testing and looking to have more specific results. Okay, again, not routinely done, and it's done, if it's going to be done, it's done after 17 weeks gestation. The next exam that we have on our list is the biophysical profile, and this is usually done third trimester, and that's to predict fetal well-being. Again, your percutaneous umbilical blood sampling readings in your book are in Pilitary, page 165, and biophysical profile readings are in Pilitary, page 196. And the BPP, the biophysical profiles predicting fetal well-being, it's done by an ultrasound. So they're going to do, and also a non-stress test. Okay, so each has a potential for a 2 score, and there are 5 things that we are looking at, and each have potential of a score of 2. So a score of 8 to 10 is right where we want it to be, and that is predicting fetal well-being. It's looking at fetal breathing movement. It's looking at fetal movement. It's looking at fetal tone, which is the extension and the flexion of the extremities. It is also measuring amniotic fluid volume, which the normal should be between 5 and 25 centimeters. And then it ends with a reactive non-stress test, which is what you want. 2 points for a reactive non-stress test. We're going to talk about non-stress tests in a minute. Okay, so it has a potential for a score of 2 each. Fetal breathing movement, fetal tone, amniotic fluid volume, and a reactive non-stress test, which is fetal heart rate with activity, okay, with fetal movement. And that is for fetal well-being, okay? It's predicting fetal well-being. So that's your biophysical profile. And we have our non-stress test, and you hear a lot about non-stress test, okay? Anytime that mom, patient doesn't feel the baby move, we can bring her into triage to get a non-stress test, okay? It is looking at babies, how they don't stress in utero. So again, for fetal well-being, we want to make sure babies are not stressing out in utero. So it's for fetal heart rate. We're looking at fetal heart rate and fetal movement. Okay, this is how babies move in utero, but they're not stressing. Okay, we have a picture so that you can better understand what we're looking at. Okay, so here's your patient. So here's your patient, and of course she's not laying flat on her back because of that vena cava syndrome. So her head of bed is elevated. Okay, here's your toco. Okay, so here's your the device. Okay, that's going to measure. That is going to measure. Okay, this is called an external fetal monitor. Okay, an external fetal monitor. Here are your two transducers. Let me make sure that you could see this. Here are your two transducers. Okay, usually the top is going to sense the uterine contractions or movement. As a baby moves, it can sense it. Okay, and this one over here is the second one. Okay, and this is a transducer that's sensing fetal heartbeat. So probably this baby, as mom is laying, probably this baby is laying on the left side, okay, or on the right side. Okay, right now I'm thinking that head is down. Okay, and baby is just in like this picture here. Okay, but baby is head down, and it's probably on the right side. So probably the spine is here. Okay, and this is where you can hear the fetal heartbeat. And that's why this transducer is here, because this transducer is sensing fetal heart rate. Now, this is a strip. This is what we call an external fetal monitor strip. And you'll hear me saying this again. Okay, the top is going to be the heart rate, and the bottom is going to be the uterine contractions. Okay, the bottom. So of course she's not contracting, so we're not gonna have those big hills up here, but there is some movement, okay, a little bit because the baby's moving. So of course it's gonna detect, it's gonna sense some contractions, gonna sense some abdominal movement. Okay, so the bottom is going to be for uterus, okay, for the contractions, for the movement, okay, the uterine muscle, and the top is going to be for heart rate. The heart rate is going to be 0 to 220. Okay, and the uterine contractions, okay, the uterine movement is going to be 0 to 100. Now, this is a strip, so how we do a non-stress test is a strip is 2 20-minute intervals. So we're going to monitor mom, okay, patient. I don't know why this can insist on going forward. I'm so sorry. We're going to have a strip. We're going to do 2 20-minute intervals. So for the first 20 minutes, mom is given a little clicker over here, and she's going to click, okay, on the clicker every time the baby moves. And this is how these dark lines, you could see these dark lines across. That's every time the baby moves, she goes and she presses on there. And that is good because babies move in utero. Before she comes in and we start, we want to make sure that she's eaten. And if not, we can give her some crackers. We can give her some juice. We can give her some water to get this baby awake. So when we start the test, we're going to run this test for 20 minutes. We're going to run the strip for 20 minutes. She's going to press on the clicker every time she feels the baby move. And then we're going to do 2 intervals of 20 minutes. And what we want to see to make sure this test is going to be a reactive non-stress test is we're going to get the baseline of this baby. So let's say normal fetal heart tones, okay, normal fetal heart rate is 110 to 160. Okay, that's the normal fetal heart rate, 110 to 160. So let's say the baseline is 140. Okay, we want to make sure that the baby is 2 or more accelerations. So every time this baby moves, we're going to make sure that 2 or more accelerations, increase in heartbeat, okay, accelerations of 15 beats per minute, and it's going to stay there and it's going to last for 15 seconds. So let's say the baseline is at 140. We want to make sure that in 2 or more of these, this 20-minute interval, You have 2 or more accelerations, okay, that are going to be of 15 beats per minute higher than the baseline. So we want to see at least 155, and it's going to stay there for about 15 seconds. That means the baby's moving, baby ups the heart rate, 15 beats per minute more for about 15 seconds, and then continues up with the baseline of 140 and continues on. Then baby moves again, and the same thing happens. Baby's heart rate goes up, 15 beats per minute, more than the baseline, and it stays there for about 15 seconds. So you want to see 2 or more of those accelerations for 20 minutes, and then the other 20-minute cycle, the same thing. Okay, 2 or more accelerations from the baseline, 15 beats per minute, higher than the baseline for 15 seconds. And that is the non-stress test. Okay, this is how we chart the non-stress test. So there's all the information, the weeks. Mom comes in. Since we're not doing high risk right now, we're doing normal. We want to make sure this is the accelerations that we are charting. 15 beats per minute, 15 higher, obviously, than the baseline for 15 seconds, times 2 or more accelerations every 20-minute intervals. The whole test lasts for 40 minutes, and that's, of course, if mom is more than 32 weeks pregnant. Okay? We're dealing with a non-high risk patient. Hopefully there's no decelerations, and you will learn that because we will be doing electronic fetal monitoring. So hopefully there's no decrease in the baby's heartbeat. Anytime there's a decrease in fetal heart rate, less than 110, which is the norm, 110 to 160, those are called decels, and we will learn about the decelerations. Okay, hopefully there's no contractions going, and that interpretation will hopefully be reactive, so appropriate for gestational age. I apologize, the screen continues to move forward. And this is how we record it. Now, finally, since the screen wants to get there so badly, external fetal monitor ruler. Okay, and this is just how you read your strips. Okay, the little boxes is a minute, half of it is 30 seconds, and the little one is 15 seconds. This is good for all of you to have. We have, when you all come to the lab, we have the strip paper that we have, and I will show you, and you will be able to apply Miller's EFM ruler, electronic fetal monitor ruler. Okay, well, that is all for the antepartum lecture. Thank you so much for listening, and hopefully you have been taking a lot of notes. Thank you very much.